Hi, my name's Mike Green. I'm an OBGYN. I'm one of our site directors in one of our California programs. And I had a situation come up on shift not too long ago that I want to tell you about. So it was actually a fairly quiet shift. I was in my call room and I got a call from the nurse telling me that there was a patient with twins that had rolled in complete. She was actually scheduled for C-section next day, but obviously she wasn't going to make it. They had put a call into her private doctor, but just left a message they couldn't get through. So I came running to the room, got there around the same time as NICU. When I entered the room, it was kind of a mess. The poor patient was kind of panicked, in a lot of pain, sort of out of control. The husband just looked completely freaked out. The nurses were sort of running around. There wasn't a lot of direction, and you could feel the sort of panic in the room. We have a tongue-in-cheek saying in medicine that the first thing to check in any emergency is your own pulse. So I figuratively did that, and kind of made a mental check, calm myself down, because it's important in these situations to have a calm outward demeanor and calm everyone in the room down. If people are panicked, things aren't going to go well. And when the doctor panics, it's over. So I was very careful to have a calm, pleasant demeanor, take charge, and the room really quieted down quickly. It was like they were looking for leadership, and fair or not fair, that's the doctor's role when they walk in. And so I sort of took over the leadership position. Everything quieted down, and people were watching me to see what to do. Second thing to do in any emergency is get help. So I asked them to please call anesthesia. I asked if there were any OBs around, and they said no, it was quiet, there was no one around. So I asked for a family practice resident to help, to get an extra set of hands. I also asked the scrub tech to go ahead and open the OR in case we needed to go that route. I did a quick ultrasound, and it turned out the first baby was head down, which is good. But the second baby was what's called backup transverse, which means the baby was lying across atop the other baby. And so there was nothing between the outside world. Once that first baby came out, there'd be nothing between the outside world and the baby except fluid and umbilical cord, which is a really dangerous situation because if that water breaks after delivery of the first baby, which it often does, all the umbilical cord is going to come out. And that's really a potential disaster. So I knew we were in a dangerous situation, a high-risk situation. Ideally, this is something that you definitely want to do a C-section on. And if you can't do that, you'd at least want to deliver that first baby in the operating room so that if something went wrong, you could very quickly proceed to cesarean section. Unfortunately, when I checked her, the baby's head was really, really low and about to deliver. And I didn't think I was going to be able to get her to the operating room in time. And I decided that if we had a delivery in the hallway and a problem, that was going to be a nightmare and completely uncontrolled situation. And so I felt that the best thing to do, even though it's normally the third choice, was to go ahead and try and accomplish this delivery in the labor and delivery room rather than try to get her to the operating room. I explained all this to the patient and her husband in a calm way and told her, number one, we're going to get baby A out healthy. That's a bird in the hand. Baby A is going to be fine. And I think baby B, I can get out healthy as well, and that's going to be the game plan. And so what I decided to attempt was to deliver the first baby vaginally and then do what's called an external cephalic version on the second baby, which means push the baby through the mom's tummy to get the baby head down and then deliver that second baby vertex the normal way. If that went the way I wanted it to go, everything would be great. But there was a lot of risk involved. If the water broke, which was a pretty high risk chance, especially when pushing on the tummy and everything, we were going to have a big problem. Or if I couldn't accomplish the version, that was going to be an issue as well. Another choice would be to try to do what's called a breech extraction, where you reach up there and grab the feet and pull the baby out the breech. But that has a lot of risk as well. And honestly, I've only done one in my career and it didn't come out well. And so I figured I do versions. I know how to do that. I'm going to go with my strength. And so that was the plan. I also recruited the patient and I said, look, I know you're in a lot of pain. I know you're really scared. I need you to help me. We need to work together as a team. And I need you to be calm. That's how we're going to get this second baby out healthy. And she really was a trooper, man. That did it. And she and I had eye contact the whole time, worked together, and that made all the difference. And so I did the first delivery, which was basically, the first delivery of a twin is easy. It's just a delivery. And so I delivered the baby, hand that baby to NICU quickly because I knew now time was of the essence. This is crunch time. This is where I got to get that baby turned before the water breaks, or we're going to not have a lot of fun here. And so I showed the resident how to show me the head on the ultrasound because they didn't know how to work the thing. And I worked on my version. The patient did great because this is a pretty painful procedure for the poor lady, but she did a great job not tensing up and letting me do what I needed to do. And by the grace of God, I was able to get that baby's head down without breaking the water. Got the head down to the pelvis, then I broke the water, which is what I wanted, and was able to deliver the second baby. Both babies had APGARs of 8 and 9, which is as good as you're going to get. So we had 2 perfectly healthy babies. And as a bonus, she didn't even have a tear. So she didn't need stitches. There was nothing to repair. She was great. The babies were great. It was a good outcome for everybody. And I was a little relieved. So after everything was done, I went and left the room. I went out to the nurse's station, and just like I got to the nurse's station, her doctor called in and had gotten the message. And so I talked to him and let him know everything was fine, explained what happened. He was extremely grateful and, said, oh, yeah, thank you. You did the right thing, and everything was good. As I hung up the phone, I thought to myself, gee, what would have happened if the hospital didn't have OBHG? What if there wasn't anyone here to take care of this problem? And, honestly, the first baby probably would have been okay because the nurses could have done that. The second baby probably would not have been. And I think we would have had a very, very different outcome if there wasn't an obstetrician in the hospital ready to take care of that situation. It wasn't that they needed me, they needed an obstetrician, which I happen to be. But it's not that I'm some super talented person. I'm a board certified OBGYN that's very competent, and that's what was needed in that situation. Any of us could have done it, but somebody needed to be there. In my opinion, if a hospital is going to be doing obstetrics, I think it's standard of care to have an obstetrician in-house 24/7. OBHG is a great way to accomplish that. We do a great job, but somebody needs to be there because this would have been a disaster. They would have had a healthy baby and either a funeral or a handicapped child. And so this was a life-changing event for that whole family, for the mom and the husband and the baby, both babies really. And so I felt really good about what we do as OB hospitalists and the difference that we make in our patients' lives.